essential to have a light touch sensation. Find them in the skin, located in the basal layer of epidermis, epidermal junction. And sometimes refer to a neurocrine and carcinoma of the skin because they share some features with nerve cells and hormone-making cells. That's about 1,000 incidents in Australia. It's a pretty rare tumor, and that's definitely less common than melanoma. The exact causes are not known. So the factors are high age, 65, fair skin, treated sun exposure, maybe UVA, HIV, chronic immunosuppression, and Merkel polyomavirus. For you, Vanessa?
So there are thought to be two pathways leading to Merkel cell carcinoma. The polyomavirus-driven pathway on the left, and the UV-induced pathway on the right. So with the UV-induced, with the polyomavirus pathway, the virus integrates the host cell. It causes a conformational change in the RB1 protein, which is a tumor suppressor protein. This conformational change prevents binding of the transcription factor ETS1, and activates the cell cycle, and this leads to cellular transformation and subsequently cancer. So the UV pathway, the UV damage causes a somatic loss of function mutation in RB1, which results in decreased RB1 protein expression and subsequent cellular transformation leads to cancer.
So the most common primary site of Merkel cell carcinoma is in the neck region, almost 50%, and it's usually around the mouth, the eyes. Are very, very rare. This is a typical presentation of Merkel cell carcinoma. Firm red nose and on the upper lip. No ulceration, and no other lesions. The T category is new HAC decision based on size. So T1 is 2 or less centimeters, T5 2 to 5. T3 is over 5 centimeters, and T4 when it invades deeper structures such as bone, muscle, fascia, or cartilage. The end category and not when there's no clinically, and one when there's regional lymph node metastasis, and 2 in transit metastasis without lymph node metastasis, so in the skin, and when there's a lymph node metastasis and an in-transit in the skin, and 3. And for this metastatic disease in M1, it's when there is clinical or radiological detection of this metastasis. Which is divided up into M1A, B, and C. A when it's distant skin, distant subcutaneous tissue or lymph nodes. B when it's metastasis lung, and C when it's metastasis or to all other visceral sites. Stage grouping comes to stage 3 when there's a lymph node of any end, 1 to N3 makes it stage 3, and when there's M1 it's stage 4, and anything M not from T1 to T4 is relatively stage 1, stage 2A, and stage 2B. And obviously, when the category increases, the prognosis becomes worse. So that's where you see here in these curves. So T1, 5-year overall survival is about 55%, and the T4 drastically decreased 31.8%. And here, this graph is no overview of when it's local, nodal, or distant disease. Local curve, nodal curve, metastatic disease. Goes respectively from 50 to 35, 13.5% 5-year overall survival. And this is an overview with regards to stage T1, stage 1, 3A, 3A, 2B. Stage 4, with overall 5-year survival respectively. So unlikely like other non-melanoma skin cancers, Merkel cell has a high propensity for nodal metastasis, about 30%, and the sentinel node biopsy is most sensitive to detect nodal metastasis, only has about a 10% false negative rate. And PET-CT is pretty good for distant mets. Both sensitivity and specificity are very high. And according to the NCCN guidelines, sentinel node biopsy is advised for stage 1 Merkel cell disease. And surgical treatment is the mainstay treatment. There's always debate about the margins. There's not enough literature about that, but preferred is 1 to 2 centimeters to the next investing fascial layer. And the NCCN guideline recommends, advises to consider Mohs surgery as well, as we do for basal cell carcinoma. Radiotherapy is mainly used to improve local regional control or to treat intransit lymphatics or draining nodal basin. But surgery is the primary option for local disease. Chemotherapy, the literature on that is also sparse. Mainly advised for stage 4 disease or when you have macrometastasis. And most common agent that is used is cisplatin. There's been quite a few studies recently on immunotherapy. They have definitely shown to shrink advanced Merkel cell tumors. Agents that have been tried are avelumab and pembrolizumab, which are anti-PD-L1 and anti-PD-1. So I'll quickly go through the NCCN guidelines, which is a nice workup, I think, of how you can approach Merkel cell carcinoma. So first you take a biopsy, you prove it's Merkel cell, you do imaging accordingly to determine the nodal status or distant metastatic status by CT scan or PET scan. And when you have a clinical and not, you should go for a wide local excision of the tumor and management of the draining nodal basin. If it's an N-node, a sentinel node is advised with appropriate immunostaining. If the sentinel node is negative, you could consider to observe the nodal basin or adjuvant radiation therapy, it says here, but that's only when you think the sentinel node might be false negative. Maybe in an earlier operated patient, or you couldn't do appropriate immunohistochemistry, you could consider adjuvant radiotherapy to the neck. If the sentinel node is positive, therapy to the neck has to follow, preferably a neck dissection or radiotherapy. With regards to the local site, you could also consider to observe or give adjuvant radiotherapy. Depends a bit on the outcomes, the pathological outcomes of the primary. I will go into that in the next slide, in a slide following this one. Say on your clinical workup it will be an N-positive neck. You feel a node, definitely FNA the node. If it's negative, consider an open biopsy. If that's negative, again, follow the clinical N-node pathway I just presented. If it's positive, go again for imaging. Maybe you've already done a PET-CT scan to determine the metastasis, the M status. And if it's an M1, the steps that follow that I will show later. If it's an M0, consider a neck dissection again. So wide local excision plus neck dissection. So then obviously you won't do a sentinel node when there's clinical evidence of neck disease.
So just go back a step. If you've got clinically palpable node, right, for stage 3B disease, you're going to irradiate that and probably the primary. So do you need to operate at all? And that's just put that in the back of your mind for later.
So this is again with regards to the primary tumor site. If you would have resected the primary with good margins, without risk factors such as lymphovascular invasion or an immunosuppressed patient, you could consider to observe. If the margins are still negative, but for example close, or there are higher risk factors such as lymphovascular invasion, adjuvant radiotherapy is advised in a relatively lower dose, 50 to 56 gray. If there's microscopic positive margins, give higher dose adjuvant radiotherapy to the primary site. If obviously there's grossly macroscopic unclear margin or the disease is irresectable, you need to give a higher dose of radiotherapy in an adjuvant setting. So this might address your question. So if you have clinical evident lymphadenopathy and you haven't done a sentinel node biopsy or lymph node dissection because the patient doesn't want it or there's another reason, comorbidity-wise, you need to give high-dose radiotherapy to the nodal basin. If it's clinically node negative, but there's a risk, you could give radiotherapy in a lower dose. And this part, again, comments on what happens when you did do a sentinel node, but you didn't follow it with a lymph node dissection and neck dissection. If it's a positive sentinel node, you have to give adjuvant treatment. If it's a negative sentinel node, probably observe. But again, if you consider there's other risk factors, you could this is just a brief slide on what you should do if there's a metastatic disease. You could consider systemic therapy, radiation therapy, surgery, or best supportive care, but it all depends, I think, of the condition of the patient. Follow-up visits usually advised from 3 to 6 months for the first 3 years, and that period becomes larger from 6 to 12 months after 3 years. Okay, so let's start with the first case. This is a 44-year-old lady who has a 5-millimeter lesion on the outer ear since 8 months, sitting here at the antihelix. And biopsy via dermatologist elsewhere shows Merkel cell carcinoma. The patient is otherwise healthy, normal facial nerve function, and no lymphadenopathy.
So, Kerwin, I might start with you. When you go back to the last picture, so you've been referred this patient. How would you approach it?
Well, we're happy with the diagnosis. So I think there are a couple of issues. Firstly, is she's young, she's female, she may be personally deeply attached to her ear, because the standard treatment would be to remove the whole of the lesion and to consider giving some radiotherapy. But there are circumstances where you consider giving radiotherapy as definitive treatment, having already established the diagnosis. I personally think there is good reason to stage the clinical nodes, the draining lymph nodes. We don't have a lot of information about Merkel cell, and I don't think we are going to learn any more if we keep hiding all the evidence by irradiating clinically negative nodal fields without knowing what's in them to start with. So I would talk to this person about why excision sentinel node biopsy. The margins on the ear really wouldn't take more than a centimetre. And in that position, you could probably still have a reasonably normal looking, albeit smaller ear after surgery, so I think it's a reasonable option. And would talk to her about doing sentinel node biopsy. If the tumour was bigger and a larger proportion of the ear was going to go, and you're going to do a total connectomy, I think that might, I think radiotherapy would be reasonable to consider, but I'd still be keen to know what's in the
Would you do any imaging for a small lesion like this? Is there a standard sort of workup for this patient?
I look at even small tumours have got a high risk of having systemic disease. If I was not going to do a sentinel node biopsy, I would consider doing systemic staging. But even in Merkel cell carcinoma, the status of sentinel node is actually a very good prognostic indicator. And if it was node negative, I probably wouldn't be doing lots of staging if I deal with melanoma. If it's node positive, then I would stage them before considering the next step.
Okay, so small tumor, your wide local excision, sentinel lymph node prior to any imaging for this patient. George, tell me about the role radiotherapy in primary treatment.
Cool. Yeah, look, it has a role. I mean, we've melted big primaries away with radiation treatment. I think our chance of local control is in the vicinity of 90% for something like this. Look, there's one randomized trial in this disease, and it's by a French group led by Jouari, French dermatology group. And what we know from them, and I agree with Kerwin, I don't think we should irradiate excessively. You know, I mean, if this travels, it'll probably be to the pre-auricular, upper sort of facial parotid nerves, lymph nodes, sorry, not nerves. And the chance of this nerve, we know from the Jouari trial that the chance of her with a less than 2 centimetre primary with decent excision, if she was to have that, was about 17%. So the first thing I'll say is when you guys pick up one of those old-fashioned textbooks that says, Merkel cell has a 30 to 40% going to nodes and a 20% chance of, recurring in transit. A lot of that's bullshit. And a lot of it's very poor evidence. A lot of the renal trials and retrospective evidence is very poor. Often, Cris would agree, we lump together in-transit mets, we lump together local recurrence, we lump together satellite recurrences. So we have tended in the past to overestimate risk of recurrence. So I think that this lady's risk of a node being involved, whether we do a sentinel node biopsy or not, is less than 20%. And with a lot of my patients, I discuss that. I say, can I watch you with ultrasensitive ultrasound? We've got Roger Uren 40 metres up the street. He can do sentinel lymph node mapping, mark out the node. I'm not saying it's the right treatment. Again, I discuss it with the patient. And I discuss the known unknowns and the unknown unknowns with her as well. She's 44. And I think, she has to make that call. One thing about radiation over cartilage is we do have a slightly higher risk, maybe 1 or 2% of necrosis of the cartilage. If Kerwin can do a neat little excision, and then maybe we can put on a lower dose, that's relevant too. I think some of the doses that you quoted were very American. They were much higher than we would routinely use in Australasia. And I think so yeah, I'd be happy to irradiate that with about 2 centimetre margin and watch the nodes with her consent and after informed discussion with the patient.
And
so I'm going to say one other thing now. I've trashed the rad-onc literature. Now I'm going to trash the surgical literature, because today I was reading, actually this morning on the train, I take the train in North Shore, and so I was reading the series that Prof. Thompson's secretary sent me late last year from University of Michigan, and they quote, hey, if you do a 1 to 2 centimetre margin on your primary, and it's less than 2 centimetres, the chance of local recurrence is like 1%. But they define local recurrence, and most surgical series do this, as occurring in immediate contact with the scar. So as a radiation oncologist, we would find that rather abhorrent to definition of local recurrence, because really it should be within the vicinity of your resection for a start, and possibly even within the area that a adjuvant radiation field might cover. So I think we have to be very careful and just understand the endpoints in each other's literature quite carefully. And in fact, if you go back to that University of Michigan thing and look at the main table, the local recurrence rate wasn't 1%, it was more like 8 to 10%. And that's exactly what the Memorial Sloan data by, Dr. Allen shows and Coit. That's the biggest single institution thing of excision of the primary and then observation, not adjuvant radiotherapy for early lesions. So I think all options on the table, and I think, again, just discuss with her. She's young. She can, I'm sure, make up her own mind. She's not immunosuppressed. That's a good thing. We worry more about people who are organ transplant recipients. I think they've got a higher chance of recurrence, and I think you should have a higher suspicion and a higher impetus for treating them perhaps slightly more aggressively. Alex, anything to add?
I think from my point of view, this could be an early lesion that's treated appropriately locally, has a reasonably low chance of relapse, and probably we don't need to touch the systemic therapy.
And she wouldn't have made it, for risk factors, she wouldn't have made it onto the MP3 trial, which is looking at the role of PET scan. So you need to have, I think a PET scan is very useful for those who have nodes or larger primaries, but less than 2 centimetre primary or no nodes. Again, I agree with Kerwin, I don't think a PET is that useful.
Can you tell us about the MP3 trial?
It's in print at the moment. That was for people with nodal disease or nasty or recurrent primaries, and that shows about a 20% upgrading with PET scan on top of conventional imaging. So that's not dissimilar to, I think, Richard, with 20 to 30% euclid. Yeah.
So one issue that might come up for this woman being very young with this disease, this tumour is she's not heavily sun exposed. She might really want to know if she's virus.
Yeah.
In fact, that was my question to both of you. With all of the trials and studies, have they tried to distinguish whether it's virus-driven or whether it's UV damaged? And then do the patients do differently? Because I had a vague recollection that that when it is virus-driven, the patients do much better than opposed to when it is UV-driven.
They certainly, the virus ones appear to respond better to immunotherapy than the non-virus Merkel cell cancers. At the moment, I don't think we've got enough data to say whether the outcomes for the early stage disease is any different. But it's interesting because anecdotally over the years, there are patients we've seen, just like melanoma is a whole spectrum of disease. I've had people who have done surprisingly well with Merkel cell and others who have just,
Well, a lot of the literature that people base their assumptions on were pre-polyomavirus days anyway. We didn't know about it.
Remember, it was only, I think it was first discovered as an entity in 2008.
Yeah.
So we don't have a lot of long follow-up. It's early.
And the studies out of Australia anyways show that only about 7% are highly driven
It's more than that.
Yes, sorry, I think it's about 20%
Right.
in Australia versus up to 80% in Germany.
Good on. So for this case, a CT scan was made to assess regional spreading of the disease. There was no lymphadenopathy, and with this patient there was a discussion to treat the lesion with radiotherapy alone to ear and neck versus surgery. And the patient chose for a wide local excision with sentinel node biopsy. And on the day of the surgery, a lymphoscintigraphy was done, which showed 2 sentinel nodes necrotic and also activity in a superficial lymph node in the right lower neck. A wedge excision was performed with 5 mm margins, and 2 sentinel nodes were identified in the right parotid tail, and 1 sentinel node was removed in the lower neck.
So just on that, what's your usual margin for Merkel cell? In terms of size, do you have a size that if it's this size to go this margin to be like melanoma?
Well, depends on what treatment we're contemplating giving them afterwards. I wouldn't take more than a centimetre for anyone that's likely to get radiotherapy, which may well be nearly everyone now. If there's someone that you're taking it out of a previous radiotherapy field or it's a recurrence, then I would take up to 2 centimetres, except it's the difference between 1 and 2, if they lost an eyelid or half their nose or something of that sort. I think there's certainly a role for radiotherapy in this disease, and I don't think you need to be doing.
Would you go down to a 5 mm margin?
Generally, no. I mean, the ear and the nose is a slightly separate issue because it can make a big difference in how you put them back together. I mean, as a general principle, you shouldn't be planning your oncological margin after you've planned your reconstruction, but I probably would have worded a little bit further in this case. But you can understand why. If it was a well demarcated lesion, most of it had gone in the first biopsy, and you're going to give radiotherapy anyway, probably not unreasonable in this context.
So she's now stage 3, so I would be getting a.
Is she stage?
No.
We haven't seen the pathology.
Oh, sorry, I did.
Yeah,
Sorry,
they've been removed. We haven't seen them yet.
Sorry.
This is the pathology.
Oh, good.
Yep. Yeah.
I was going to be
So, the report showed a residual Merkel cell carcinoma with a depth of invasion of 1.1 millimeters, no cartilage or muscle involvement, no LVI or PLI, and the margins were clear with 5.5 millimeters. And the initial report showed no positive nodes. So interestingly, the good news was brought to this patient that the nodes were negative, but the supplementary report after the immunostainings showed that there was a small deposit of Merkel cell carcinoma in one of the subcapsular sinuses, 0.6 by 0.1 millimeter, but like you said, it upgrades the stage to stage 3. So that's why it's important to wait for the immunos. So the patient was called back in.
And I completely agree that no preliminary reports should be put out and just wait for the final thing, the final package.
So, Ruta, why do we have a higher rate of false negative sentinel node biopsies in this disease than in, say, melanoma or breast cancer when surgeons doing sentinel node biopsies?
So Vanessa will be showing this
Example, right?
Yeah. And there is a beautiful section in the picture that we will show.
No. I'm just saying, why do we?
Positive.
Yeah, it's literally positive, but it was a false negative until you got the IHC.
I see. So we'll be looking at the lymph node, and it will be very quite obvious there. So do you want to go through right from where you saw the first picture? No, we'll do it from the first picture. Yeah.
So Richard's already pretty much said
all the differences on the slide. So the right ear lesion with the ear wedge,
showing residual Merkel cell carcinoma invading the subcutis to a depth of 1.1 mm. There's no lymphovascular perineal invasion, and 1 out of 2 carotid tail sentinel lymph nodes is positive for metastatic Merkel cell carcinoma with clear margins. So the tumour cells were small and round with a high MC ratio, showing speckled chromatin and some nuclear moulding and a few mitoses. The sentinel node in the right carotid tail. So this is the H&E, and you can't see the cancer, where the cancer is, basically on this slide.
So basically, even if we go to the previous slide, do you want to go to the previous slide? These are the tumor cells, and these are the lymphocytes. And they basically have the same shape and size and similar nuclear characteristics with small, dense chromatin. When we go to the next picture, which shows the lymph node net, when we look at the area that corresponds to the cytokeratin, it looks exactly like the rest of the lymphoid tissue. It would be impossible to make the distinction. Lymphocytes obviously don't stain with cytokeratin, which is an epithelial marker, but Merkel cell carcinoma does. And that makes immunohistochemistry quite relevant and very, very important. And the other factor is also that with the sentinel node protocol, we are studying things through multiple levels. With a 0.6 millimeter lesion, it's quite possible that it's not present in the first level at all, and then comes up as you cut in deeper. So in that sense, given the basic cytology of the tumor and the size of the deposit, it's quite understandable how it was missed on histology only.
So, what's next?
So can I just go back to that case again? George, you make a point that if the sentinel node is positive, you will CAT scan the patient.
Yes.
So that's not for, is that for regional or for distant disease?
Distant, because she's at high risk of distant disease. We know she's got regional disease.
So you ignore the uptake in the local and regional area, just mainly look for distant.
Well, it's going to be slightly warm there because of the recent surgery anyway.
So if you have multiple other nodes light up in the neck, it obviously tells you something.
Absolutely.
but you're looking for a reason to consider other forms of therapy other than the radiation.
Yes.
And you know, as a baseline for further monitoring too.
So I'm just going to go back. So in that case, you highlighted you need the immunohistochemistry. Do you do that on your primary as well, or do you just do that on the neck node?
So for Merkel cell carcinoma, the basic immunostains are done on the biopsy, on the main specimen as well as the neck node, because if you wanted to think about it, it's more like a small round blue cell tumor, where what you have is sheets of cells with very scanty cytoplasm and small nuclei, which may or may not show stippled chromatin. The differential diagnosis is very, very wide. Depending upon the age of the patient, it can range from a metastatic lung cancer, small cell cancer, to Merkel cell carcinoma, or in a young patient, even a variety of sarcomas. So you have to prove that it is a Merkel cell carcinoma by doing a panel which includes neuroendocrine markers like chromogranulin and synaptophysin, CK, which shows a very specific pattern of staining, and basically other things to exclude, like PTF1 to exclude lung tumors, depending upon the differential diagnosis.
So George, now we got a patient that's got a clear margin on the primary, but a positive sentinel lymph node, so N1A.
Yep.
Is there a role for you, or is there more role for Kerwin to complete?
That's up for discussion.
Where's the current evidence pointing to at the moment?
She needs further treatment, and it should be either radiation. And if I was going to treat the hemianec, I'd also treat the primary, because it was only, I think, from memory, 5
in the field anyway.
Yeah, so it's going to be in the field and make sure we bolus that to get the dose up there, and that would be 50 gray.
On the neck?
Yep. For microscopic disease in Merkel, you need 50 gray and 2 gray per day equivalents. For macroscopic, you need at least 55 gray.
And
those are Australian guidelines from Queensland. The Coulson and Fulton, they've gone through and analysed, for local control. So there's reasonably good local data for the right doses to use for Merkel cell. And I think if you recall, Richard, the doses you put up were obviously very US based, because they went up to sort of 60. And generally, Merkel doesn't need that much dose. It's, again, quite exquisitely radio sensitive compared with most other cancers.
Alex, do you have a role at this point, or sort of just wait till?
Yeah, probably not. There has been sort of some retrospective studies that suggest that the addition of chemotherapy may be beneficial. There was a bigger SEER database analysis that was in prospective stage 3 patients, adjuvant radiotherapy versus adjuvant chemotherapy plus radiotherapy. It didn't seem to show advantage to chemotherapy. It was certainly encouraged as well. The first surgery of the nation radiotherapy.
So if the patient wanted completion neck dissection, what would you guys say?
As with my melanoma, I would basically extend my dissection on the pattern of lymphatic drainage in the lymphocytogram. I would expect from the ear going through the parotid bed that it would be into the upper neck, lymphatics, and follow the external jugular vein down to the base of the posterior triangle. So my standard in this would be a parotid on level 2 to 5. If there was evidence of second-tier drainage or direct drainage to the submandibular triangle, I would include the submandibular triangle, but generally it doesn't actually go that way from the ear. It's quite uncommon to get a submandibular node from the pinna.
So we've been talking about viruses and etiology for this. Are we trying to would you be trying to differentiate that? Is it value-driven or is it non-value-driven at this point?
So it was not done at the time of the diagnosis, but we did it for the presentation.
Cool. Yeah.
And I don't, is there a picture?
No, because there's nothing to see.
Sorry.
There's nothing to see.
But yeah, because it is such a small tumor, there was nothing left to.
Is it something easily done? Is it sensitive?
Oh yeah, it's immunohistochemistry, and it is quite easily done.
I think is a false positive high or false negative high?
I think it is pretty sensitive and specific, but it is done only on a research basis and not for clinical work. So I will not be able to quote the numbers of sensitivity and specificity off the top of my head. But it's a simple immunohistochemical thing.
I mean, it's worth pointing out that she's unusually young for Merkel cell cancer. I'm used to, in the rat especially, treating 80 and 90-year-olds, not 44-year-olds. Very much an outlier from what we see.
Do you know if there's any time on the horizon to try to answer that question at the moment?
Which question?
If this is virally driven, should we, just like HPV, just sort of along the line of HPV story, should we think about stratifying?
How many years has it taken for the head and neck community to sort of start thinking about changing paradigms for HPV and oropharyngeal cancer? Because I think on the same note, this is still relatively new, and the numbers are so much smaller, so to actually do a randomised trial, I think would be strong. Yeah.
I mean, you're talking about modifying doses of radiotherapy for the we haven't actually done the study whether surgery versus radiotherapy is better or not.
And we don't even know that polyomavirus does better clinically at this stage. It does respond better to immunotherapy agents, but we've got very positive evidence on that. So I think to take that leap of faith, you'd have to be very brave.
Yep. Okay.
I think in general you'd be using lower doses than you would for things like squamous cell carcinoma anyway. So you're not talking about the fibrosis in the throat and the dysphagia and the xerostomia and all that sort of thing. Far less an issue in this disease.
So PET-CT was done for further staging, which showed no distant metastatic disease. And this patient received adjuvant radiotherapy to the parotid and the upper neck of 54 grade. So the local site was not included in the field.
Just on that, you asked was 5 millimeters enough. I think it was encouraging in the pathology that the pathological margin was actually wider than the recorded surgical margin, which means that at least there was no disease beyond what was visibly naked with the, visible with the naked eye. So in that sense, it would have made me comfortable.
Probably means the original margin is actually larger, doesn't it?
Yeah, it probably was larger, but certainly it implies to me that there was nothing beyond what was macroscopically visible, and I think that's important and reassuring.
And the patient is still in follow-up, and there's no evidence of disease, so she's disease-free for a couple of years now.
And just a follow-up.
Sorry.
What was the schedule of imaging? Follow-up? Just want to have a PET scan.
I open that question.
I can't recall that right now, actually. So.
Open up to the.
Well, that's the question: how often and for how long? That's the question that's still being answered. MP3, I'm not sure. Most of the people who are going to recur will have recurred even by 18 months to 2 years.
80-90%. It's virtually everyone will have recurred by 3 years.
Yeah.
Most people will have recurred by 2
I think you wouldn't need to continue PET scan.
I think she was petted once and just clinically followed.
There was another trial from the UK. The protocol was sent just last day or two, which was looking at treatment of the primary surgery versus radiotherapy, and they were talking about doing PET scans as part of that study. But they wanted to do them at 1 or 2 years. Lots of comments from the Australian people. They
make far more sense.
Do them earlier because you expect early recurrence, and you'd expect most of them by the 18 months to 2 years.
Stop.
In your practice, Kevin, how would you follow them up, and how would you image?
Look, my practice it probably wouldn't be very much evidence-based. I would tend to follow my HCC and my melanomas, and these all the same. I'd see them every 3 months for 2 years. I'd see them every 6 months up to year 5, and once a year after that. In terms of, as I said, I'd probably stop doing systemic staging if someone got to 2 or 3 years here, would be, what I would think about. But the few patients I've had that have had PET scans with Merkel cell carcinoma, they come in saying, when's my next PET scan? And in fact, one of them has had a tonsil cancer diagnosed, and they follow up. So now he's getting his PET for his Merkel and his tonsil cancer, but he is about 8 years out from both of them. So.
But are you every 6 months, every 12 months?
I tend to do, until we've got one, I do one at 6 months, so relatively early. And if it's not present on the 6 month scan and there are no symptoms to suggest other problems, I'll do one yearly after. If there are any symptoms to suggest systemic disease, or if there's another event like a local recurrence or a node pops up, then that will start on.
George, is that your practice?
if they've had nodes 6 and 12 and close clinical observation.
And then if nothing for 6 and 12, do you then do another year, so 24 months now?
If they had an echo infection with that pathology, patient, or are there any patients that have metastases in the node, you would consider molecular management radiotherapy too? You had the node.
Well, firstly, in the decision to do the neck dissection, or not, the first question I would ask Dr. Rube is, will you not irradiate this person if I find no more disease involved? And if he says I'm going to irradiate this person, whether you've got negative pathology or not, then I probably wouldn't do the dissection. If he says, look, this is a very low volume of disease in that single sentinel node, it was only found on immunohistochemistry, and the rest of the neck is clear.
That's probably the answer I would have given too. If it's a negative neck dissection, she could avoid radiotherapy, but the chance that it's hard to predict that it will be a negative neck dissection. So I'm sure that's right in the decision for radiators. Yeah,
and essentially that's the reason for doing sentinel node biopsy, is to considering surgery is to avoid doing radiotherapy in people that you would otherwise give it to. And although there's a reasonably high false negative rate for the sentinel node biopsy reported, even in those small series here in Sydney, I think they even reported a false negative rate of about 20%, but the other 80% did not fail.
Yeah.
And so that's 4 out of 5 people who didn't get radiotherapy.
Yeah.
And didn't come to grief. So I think that's worthwhile.
We might move on to the next case.
Yep. So this gentleman is 75-year-old, and he has an asymptomatic pre-auricular lump on the right side. It's a firm but mobile mass, and he has a history of multiple skin cancers, SCC, BCC, no other relevant comorbidities despite his age. He does have sun exposure in the past, no immunosuppression, and no other lymphadenopathy. The facial nerve is working well. So asymptomatic right pre-auricular lump.
So coming back to you, so different patient, older, sun exposed. So assuming that we have there's the FNA, right? So we're wanting to jump to FNA.
Okay. So
I was going to say the first thing I'd do, do get a fundamental aspiration biopsy to sort out which of these diseases it is. That presentation's got metastatic SCC until proven otherwise, so that's where I'd start. If an atypical lymphocyte replace or something non-diagnostic.
Yeah, so he had a lesion of 16 by 14 millimeters with increased vascularity, but a non-diagnostic flow cytometry.
So in that circumstance, he needs an excision biopsy with a node and a parotid. An excision biopsy essentially means doing a parotidectomy in a typical patient that's likely to be SCC. I probably would have done parotid level 2 to stage the upper neck nodes in the one operation.
Yeah.
So I just want to put the question to you. FNA in Merkel cell, is that difficult for you?
Very. So as I said, and as we've been looking even on histology, because the cells look so much like lymphocytes, I can quite imagine why this may have happened. There can be two reasons. One is that what was sampled was indeed the periphery of the lymph node with a very small met, and the met was not picked up at all in the needle sample. Or the second thing could be that there was no cell block and a very paucicellular smear with a few scattered cells, and you can't tell whether they're lymphocytes or not. Whatever the cells were, they did look atypical, and they did make them worry about a lymphoma. So they were not normal looking cells in any case.
Would the cell block help you in that?
Yes, the cell block would definitely help you, because if you do lymphoma stains on it and all of them are negative, then you start wondering about a carcinoma, melanoma, and once you start looking for a carcinoma, you home in on Merkel cell with that kind of appearance.
So you could do that on a true cut biopsy.
True, yeah, of course.
Yeah.
Yeah.
Yeah, so the operation, a right parotidectomy was performed, and
So he had a single lymph node, seen here, body wall margins.
The architecture is completely effaced by tumour.
So the tumour consists of sheets of cells, minimal cytoplasm, small round hyperchromatic nuclei with stippled chromatin, and a lot of mitotic activity. There was lymphovascular invasion and extranodal spread to spanning 1 millimetre in length, and the tumour extended to the diaphragm margin. On immunohistochemistry, all the neuroendocrine markers are positive. Chromogram synaptophysin shown here, and CD54 positive. Cytokeratin 20 was positive, characteristic perinuclear dot-like staining shown here, which supports the diagnosis of metastatic Merkel cell carcinoma, unknown primary. The Ki67 proliferation index is 90 to 95%.
So Ray, this is good news that he's got a ticket to that man. They do better or worse?
There's no positive patients with unknown primary.
Yeah. They do a lot better in the
I
study.
think they do better.
Yeah, they do. Not that that's going to change our treatment paradigm. It's good news for him.
Is that because the practice would have regressed? So,
Yeah, maybe this is a possibly logical. Who knows? Who knows? But there's no studies that support to get a prognosis for those with unknown or occult primary.
Do you see benign Merkel cell?
because they're so difficult to see, and because we don't routinely do synaptophysin staining on lymph nodes, if you're not looking for them.
Oh, and I asked the question because in melanoma, there's a lot of new cases of benign nevus cells, and so it's conceivable that some of the unknown primaries are primary melanomas in the lymph node.
Right.
There's nothing to suggest that this.
It could be possible, but no one has ever.
The small.
So when you got this patient now that is diagnostic thyroidectomy, some margins involved, now we finally got the diagnosis of Merkel cell, which is now metastatic or infancy. Would you now starting by imaging, or would you send it straight to?
No, I would certainly stage them, and probably do a PET scan if it was available to me. Merkel cell itself is not an approved indication, but head and neck cancer is. So because most of these Merkels in the head and neck, I always tick the head and neck box.
Head and neck extends down a lot.
So yeah, look for evidence of systemic disease. This person has indications for radiotherapy, even in what's been removed already. So I don't know that I would necessarily be suggesting any further surgery because unless I've already had their radiotherapy for their SCC. And would, I guess, be making some inquiries with Alex and others about whether there's a role for other adjunct therapy.
Are you going to talk about this trial?
Yeah, well, I guess broadly there's a lot of interest in a trial that looks at adding immunotherapy to radiotherapy.
So, George, if Kerwin sort of referred this patient, PET scan is needed, refer to treat, where would you treat? What sort of neck would you treat?
So, the private bed and the head and neck.
Level
50 grade. Oh, down to the superclad fossa.
So 2 to 5, 1 to 5? 2 to 5. And sorry, Alex, you were saying that there is some role of chemotherapy or immunotherapy.
But that's on a trial.
Immunotherapy on a trial, obviously, because there's not great support for this chemotherapy. And so broadly with immunotherapy, what's been found in advanced disease, we know that Merkel cell carcinoma is very sensitive to chemotherapy, but the responses are often not curable. And what's been seen with immunotherapy is that the responders are often very prolonged responses. So patients who've had 1 or 2 lines of chemotherapy, around 30% of patients respond. About 2/3 of those have these ongoing responses for 12, 18 months until And then the other factor is that whereas the treatment's now moved into patients who have not had chemotherapy, the response rates are shooting up to sort of 65 to 70%. So it seems to be that pre-treatment with chemotherapy diminishes the effectiveness of immunotherapy. By immunotherapy, we mean the checkpoint inhibitors that you mentioned, avelumab and pembrolizumab and nivolumab, so blocking PD-1 and PD-L1 pathways. So it does seem to be a disease where the sequence of treatment may actually be quite important, and the immunotherapy in a chemotherapy naive, or in the patient being chemotherapy naive, may work much better. That's the hope of bringing this forward.
And is that trial up and running? Or
no, this is a proposed trial.
Proposed trial.
Yeah.
There's a similar trial.
Yeah, it's very exciting, I think. The problem we know from our own experience here from the trials, as I think Alex mentioned earlier, given chemotherapy plus radiotherapy together, particularly the first phase of those trials with a platinum agent and etoposide given with RT, just as they were getting their nasty mucositis, they were also getting neutropenic. So it wasn't a very symbiotic combination. And in an old patient population, although they did well, they had a lot of toxicity compared with RT alone. The MP3 trial I alluded to, that used weekly carbo and then gave the carbo etoposide afterwards, cisplatin etoposide afterwards. But again, we've got no randomised evidence to suggest that that's better, and maybe the patients we put on those trials were better performance status or people we thought would tolerate chemo. So, and again, you know, if what Alex says is true, then you could compromise subsequent immunotherapy by sort of overuse of chemo up front. So I don't think that trial paradigm has really moved or evolved or has much future in that context, in the context of immunotherapy available now. I think that the next wave of trials will be much more exciting.
And so one of the interesting features with immunotherapy is that patients who are virus positive, and often those viruses don't understand that they've actually got mutations of T antigen that's integrated. So many of us have Merkel polyomavirus, but you actually have to acquire a mutation within the viral genome, and it's very antigenic, and so it's a good source for triggering an immune response, and hence the role of checkpoint inhibitors to overcome depletion of response. But for the patients who are virus negative, they usually got heavy UV damage, which is also highly immunogenic. So both patients sort of have good pathways leading to activity of immunotherapy, checkpoint inhibitors. So one of the first trials, with pembrolizumab, there's actually no difference in whether you were PD-L1 positive or negative. Now, a very small number. Your chance of responding was similar. And most of the patients who were PD-L1 positive were virus positive. But it just goes to show that you've got these two sources of antigens, that antigenic signal lends itself to effective immunotherapy.
So, Richard, you want to?
Yep. So you already mentioned this. Stage 3 disease. The patient received concurrent chemoradiotherapy to the carotid and neck, and finished with that in December 2008.
Probably was on the trial, actually.
With a 50 grain total, and received adjuvant chemotherapy after the MP3
trial program.
She had post-contrast CT neck and chest at several moments actually in time. So 6 months afterwards, 12 months afterwards, 1.5 years afterwards, and then 2.5 years after. That was the imaging.
With the MP3 trial, George, does that dictate systemic staging as well, or does CT chest and neck?
No. The PET scan was nested into that trial, so that's where the data for that 20% upstaging comes from.
Okay.
Yeah, and that should be published shortly. I think it's just been sent to Jane Nero by my
those patients with your department now, I take it you would be looking for current chemotherapy. Probably not. Yeah. What about looking the outside setting with Crohn's disease? Does that change?
Yeah, that I think is a rationale for using things. And I think sometimes we would get our arms twisted a little bit with very adverse features like the vascular invasion or post-margin.
Okay, so we'll move on to the next case. 73-year-old male with a lesion around the left temple since a few months. The GP took a biopsy and it showed to be Merkel cell carcinoma. And when the patient came in on physical examination, it was a soft subcutaneous lump from about 1.5 centimeters, no lymphadenopathy with normal facial nerve function, no other comorbidities or immunosuppression.
So we should probably just move on to investigation and go on to some discussion.
Okay. So a wide local excision was performed. Margins were not documented, but the frontal branch of the facial nerve managed to be preserved, and the patient also received a sentinel node biopsy, and a local flap was done to close the defect. 3 sentinel nodes were removed, mid-parotid, lower parotid, and 1 in the upper neck at level 2. And the histopathology shows that the local margin was clear, and the closest margin was 2 millimeters. And 1 of the nodes was involved, which makes it a stage 3 disease.
Just a sort of comment, Cohen, if I may, on the central lymph node. If it is positive in the parotid versus positive in level 2, does it change the prognosis of the patient?
Does it change the prognosis?
Does it change?
No. In fact, if you look at the staging that was put up at the beginning, the size and number of lymph nodes have no impact on the staging system as it's been presented now. So, in practice, does it? I don't think there's any data there to really know. Yeah. No one's really gone and dissected to that much detail.
So what would you do in this case? Now we've got 1 essential lymph node that is positive, 2 millimeters deep margin, but clear.
Oh, look, I think much the same discussion we had before. Your choices are to, well, whether you radiate the primary or not. I think it's a close margin with evidence that it's spread by the lymphatic, so I think that's a good reason to treat the primary site. The regional lymph node basin needs to be treated, and you need to have the discussion about what's the best way to do that. If they're going to have the radiotherapy of the thyroid anyway, then I think it's reasonable to irradiate the nodal basin. If there are reasons not to do that, or the patient wants to get it all over and done quickly, and understanding that they might need that radiotherapy anyway if we find more lymph nodes involved. But if there's no other disease in the neck, they might avoid radiotherapy and have that discussion.
George, the radiotherapy for this then is before 50 grade, including parotid base?
Yeah, but if you're, the important thing here is I think the margin's really tight on that primary. So don't all in continuity. So all the way down, top to bottom.
And the primary also 50 at this point?
Yes, because it's microscopic. It's all microscopic.
Yeah. Okay. Before that was done, a PET CT scan was made, which was clear. Only just some post-operative changes, but no distant metastatic disease. And the patient received radiotherapy to the temple and neck, 50 grain, 25 fractions. And 3 months after that, a PET scan was done, which was clear.
Cool. Now, in terms of follow-up, the 5 years is where the Merkel sort of the risk is disappeared. Like, would you have happy to discharge them at 5 years?
I discharge people at 5 years, and after 3, I go down to pretty much annual. Not longer. 90% are going to have it for 3 years.
And Alex, anything else sort of you want to comment on the use of chemotherapy in Merkel?
I think
I was about to say, I guess I was expecting the next slide to come and say the PET at 6 months.
We haven't had anyone else. But we're hoping that Alex will tell us about the use in a systemic disease.
Yeah. I think there's a real push on to make immunotherapy the first treatment of choice for systemic therapy. And I think the NCCN guidelines are going to be modified to that effect soon, so that immunotherapy becomes a recommended.
So even without systemic disease, even a systemic disease, so with systemic, sorry, yep.
Look, if someone's got overt systemic disease, they get a fabulous response with chemo, melts away, but in about 80% of cases, it's back within, on average, 8 months, I think it is. It's quite frightening how quickly it rebounds. So you're really temporizing for a very short time with old school chemo and Merkel cells.
See these patients where the disease actually starts to regrow for the next cycle.
And the other thing is, remember that, again, I will reiterate that I've treated 100-year-olds with Merkel cells with RT. I think my record is 103-year-old out of the nursing home with a mother evolution on her hand. And these people aren't sick for chemo. It's just torturing them. So, again, you've got to really take the performance status of the patient into context in this disease.
So if you want to give immunotherapy in a systemic disease, what sort of response rate are we expecting?
So if they've had prior chemotherapy, probably around 30%. So 30% response and about another 30% stable disease. If they're untreated, chemotherapy naive, you're looking at 60 to 70% response. And generally, more than half of the response is seen to be cured.
And if you have resistance or sort of lack of response, when do you see them? Until like melanoma, about 12 months, got a big drop-off there.
So there's some people who are primary refractory who don't respond at all to immunotherapy, and then there's a bit of a drop-off over the first few months, usually sort of 3 to 6 months, and then it seems to plateau out.
And so if you do keep on immunotherapy, is it lifelong, or do they, after a few years, and then you see a change in mutation again, and this means that they can continue on? So the people who achieve response, some of the avelumab trial, I think, just stopped treatment at 12 months. One of the other drugs, they kept going up to 2 years. It doesn't seem to be a huge amount of drop-off. So it's a bit hard to know how much treatment you need, whether 6 months might be enough. The general feeling is 12 months, at the moment, which is probably really cautious. If someone's still in remission, stopping at that point is not unreasonable. And although it's not on PBS at the moment, there's a company that make avelumab that basically have a global program that's been pretty open to giving access to cost. When you put these people on, are they at higher risk of other type of skin cancers?
Not as a result of immunotherapy, but for in case you have patients who have lots of systemic therapy,
So we might open the question to the floor. If there's anyone that has any burning questions that you want to ask the expert panel while they're here. So is there something you want to share with us?
I just had the papers of the avelumab trial, just showing the survival curves, which essentially is Alex explains. When we had a discussion about it, someone put up a slide that compared the chemotherapy with, as you say, those early recurrences. I don't have that picture, that's the one I really wanted to show. But yes, the avelumab in the setting of people that have had first-line chemotherapy, prolonged durations of response in about a third of them. And then there was talking about first line, there was a Pembro study which showed actually quite high and durable responses. The median survival was actually being reached in the trial. There is this push to get immunotherapy as first line. At the moment, you've got to have some chemo first before you allowed to give you any courage.
Which is probably a bad thing, like you explained.
Any questions? So if not, then we might draw this session to a close. I would like to thank our presenters and our